Hello, Michael? Michael is not on then. So do we have Peter McGaritty then on? Peter McGaritty, are you there?
Unmute. Yeah. Hello.
Perfect. We can hear you, Peter.
Excellent.
So I will share your presentation on board just in a second.
Okay.
Peter McGaritty, okay. Right. You have 3 minutes to present, Peter.
Okay. Well, hopefully it won't be too much of anything groundbreaking or new. I suppose this is just really a poster on sort of the bane of most spinal surgeons' life, and that's sort of CSF leaks or iatrogenic CSF leaks following surgery or in surgery. It's really just a brief recap on them and how we in sort of in Belfast tend to manage sort of perioperative CSF leaks. So I suppose we all know they're sort of rare in non-decompressive surgery, and they tends to be the greater the complexity of the surgery, the higher the risk. So there's unsurprisingly there's a higher risk, sort of about 1/5 risk of CSF leak in revision surgery, and this isn't surprising really, given sort of the underlying scar tissue and the unnatural anatomy from previous surgeries. Uh, how do we pick them up? So perioperatively, I suppose we can see it. So if we see CSF, we usually use a few explicitives under our breath, and then hopefully repair it there and then. But sometimes it doesn't declare itself sort of till after the surgery. So after surgery, we see the wound leaking through, or the CSF leaking through the wound. Patients can complain of headache and nausea. It felt sort of secondary to sort of the low pressure state. Very rarely, patients become acutely unwell, so they can develop sort of the degree of herniation can be so significant they can develop large acute subdurals or significant herniation syndromes. And I suppose here I've put in one must always be careful when we're using a negative pressure drains, I suppose, that we haven't got a CSF leak, because there are documented cases of sort of patients coning following placement of sort of a negative pressure drain, such as a Redivac drain. Um, and then I suppose that they tend to have broken early into sort of the first day or two after surgery, and then late patients can present sort of again similar symptoms. Sometimes can be sort of manifest in ways that might be pointing more towards an infective cause or causes of infection. Um, so it's just to be aware of those, and really the key principles when dealing with any CSF leak is recognizing and exposing the leak. So perioperatively, if you see a leak or if you're suspicious of a leak, increasing the surgical field if possible to sort of expose the dura in more detail to see if you can find the point of leak, repairing it there and then when you think you've repaired it, you think you've got a good job, rather than taking your word for it, I suppose you need to test it. So you need to perform some sort of Valsalva, so get some sort of positive pressure going to sort of really to test your repair to make sure you've done an adequate job. So how do we manage leaks? Well, I suppose if we're envisaging that there's going to be a leak, sort of for complex, or usually sort of complex thoracic or sort of upper lumbar surgery, particularly if it's sort of multiple redo surgeries, we can prophylactically place a lumbar drain. What we tend to do sort of in Belfast is for most of our spinal surgery, open spinal surgeries, would be to sort of perform a thoracodorsal flap. And this just sort of provides a much more thorough or sort of better closure. And what we can see is so on this, for example, we can see that essentially the CSF has further to travel if it is leaking. So it's all about containing the CSF and hoping that it scars over with time, but ultimately it has further to travel, and usually there's a better sort of sealant in theater. So what we can do, so small CSF leaks, particularly if we're performing minimally invasive surgery, sort of 1 to 2 millimeters, tend to ignore them, and they usually scar over or close by themselves. Medium size leaks, so up to about 4 millimeters or so, and holes in the dura. We often bipolar, see if it closes, or sometimes we'll take a bit of surrounding muscle and plug the hole. And usually this is enough. Anything really over sort of 5 millimeters or so, we're starting to realize, I suppose, that this needs really primary closure, be it sort of primary closure with sutures or suturing in a graft of some sort. And that's if we see the CSF leak there. As we all know, post-operatively, our CSF leaks may not declare themselves until you've gone home and thought you've done a great job. And then the next day the patient says, oh, there's this water leaking out my wound, or I don't feel 100% right. And then subsequently we find they have a CSF leak. And the big question for managing the post-operative CSF leak is it contained, i.e. is it not leaking through the skin, or is it non-contained? So is it leaking out? And in the non-contained ones, you're usually going to have to do something. You can try the lumbar drain if anatomy allows you to, or a lot of the time you're going to have to take the patient back to theatre and explore the wound and hopefully find the hole and repair it. For the post-operative contained ones, again, we often say we'll trial a period of bed rest, so lying flat. A lumbar drain may be feasible again, and ultimately, if they're still symptomatic, or then we're going to have to take them, or their pseudomeningocele is getting bigger, for example, then often we have to take them back to explore the wound. So really, I suppose in summary, again, sort of with all spinal surgery, particularly complex revision surgery, you should ultimately be planning or thinking, well, a CSF leak is a very high possibility here. If you're suspicious that there is a CSF leak, there usually is. If you can repair it intraoperatively, obviously we would do so, but ultimately we need to act early and aggressive, for particularly on contained leaks, due to the risk of possible complications, particularly infection and sort of the non-contained leaks, along with the clinical symptoms that the patient feels. And really that's everything.
Thank you so much. It took you 6 minutes, which was
6 minutes.
like double the amount that you had to take. That's
Sorry.
fine. The next presenter will be Michael. Michael, are you here? Michael Rainey? Michael, I cannot hear you. Okay, so let me see if I can find you here in the participants.